here, and today I'll be talking about the topic of rehabilitation disposition in the post-acute phase in patients after a lower extremity amputation. My advisor is Dr. Yu. Does this work? I guess I had to do that. Okay. All right, so just an outline here. I'll be going through some introductory material and epidemiology. Following this, I'll go into a description of different rehabilitation settings, and then I'll discuss a TPT, or type, place, timing framework, which is a way of thinking about clinical outcomes in regards to different aspects of rehabilitation. And then using this TPT framework, we'll dive into some of the outcome studies that I've found. We'll discuss the determinants and patient characteristics in relation to rehab disposition. And then finally, I'll touch on some current policies and challenges within this population. I'll give a little bit of recommendations based on the data that I've found, and then conclude the talk. So in terms of epidemiology, 1.6 million people, or 1 in every 190 Americans, were expected to have limb loss in 2005. And with the aging of the population and high prevalence of diabetes, this number is expected to double to 3.6 million people by 2050. With surgical outcomes, it showed that 34.5% of patients will have a repeat amputation at a higher level within 12 months, and that 50% of patients undergoing major lower limb amputations for ischemia will require amputation of the contralateral limb within 2 years. The survival following amputation in patients with vascular disease is quite low at 31% within 5 years after surgery, and the medical care costs are quite significant at estimated $4.3 billion per year in the acute and post-acute medical care costs for Medicare beneficiaries. In terms of etiologies, this vascular diseases accounts for the most common cause for amputations, and this is the population of my focus for this talk today. This vascular diseases includes both peripheral vascular disease and diabetes. Of note, diabetes increases an individual's risk for amputation by 12 to 15-fold, and accounts for over 50% of non-traumatic amputations in the United States annually. Other etiologies that I mentioned here includes traumatic, tumors, infections, and congenital limb deficiencies. So the question becomes, why should we care? Well, with the expected increase in amputation prevalence and the associated healthcare costs, it will be very important for us to determine where these patients would have the most benefit for optimal functional recovery. Amputations confer significant impairments in patients' functional status, affecting their productive activities and quality of lives. Other problems includes pain, contractures, wound healing, and psychiatric issues and coping. It's generally believed that rehabilitation by enhancing functional recovery can improve quality of life and reduce the economic burden associated with major limb loss. Yet there's ongoing concern that healthcare professionals really have little evidence in regards to the value of rehabilitation treatments. And there's currently no consensus regarding the proper rehabilitation dispo for patients after a lower extremity amputation. So next, we'll look into different levels of rehabilitation that are available to these patients after amputation. So there are various levels of rehabilitation available. The continuum includes comprehensive inpatient rehab units, which can be attached to acute care or in freestanding hospitals, such as where we are today. You have subacute rehab facilities with less intensity of therapy. There are skilled nursing facilities, outpatient rehab facilities, and as well as home through home health care. Of use to the clinician and physiatrist would be an understanding of the utilization of these rehab services, which is what was done by Dillingham et al., who studied the patterns of rehab discharges for patients. He used the Maryland statewide hospital database and reviewed the discharges occurring from 1986 to 1997. And the key findings from this 11-year study regarding rehabilitation disposition revealed that 40.5% of patients were discharged home without any services. 37.6% of patients were discharged to a skilled nursing facility, of which 52% were transfemoral amputations. 9.2% of patients were discharged with home care, and only 9.6% were discharged to inpatient rehab facilities, 14.4% of which were transtibial amputations, and 8.2% were transfemoral. This graph here depicts the trends of discharge destination. We see that over time, there's decreasing rates of discharge home. Which would be the line with the filled in circle. The proportion over this period of time declined by 60%. There's increasing rates of discharge to skilled nursing facility by 77% during the same time period, which is this other line with the open circle. And then at the same time, there was a 6.5-fold increase in inpatient rehab facilities, which you can tell by the square right here. And it was noted also that in transtibial amputations, saw the most decline in proportion going to home without services and the largest increase of use of inpatient rehab. Sorry about this. Okay, thanks. So the study offers an explanation for this pattern shift that we had just seen in this graph here. There was a decrease in acute care length of stay from 27.4 to 14.1 days, and this likely necessitated additional care in a skilled nursing facility or inpatient rehab in order to achieve medical stability and functional level that's sufficient enough for these patients to return home. Of note, the decline in acute care length of stay was consistent with hospital trends throughout the nation. Further, Dillingham et al. Postulated that there were possible economic incentives through the prospective payment system for rehab facility, which may have influenced the disposition as well. So next we'll discuss this type, place, timing framework, which I alluded to earlier in the presentation, in thinking about outcomes in rehabilitation. In general, knowledge about best practices in rehab is limited, as rehab involves long processes of phases that are not well defined, not sharply delineated, or standardized. So in thinking about the appropriate rehab level of care, having simply a higher level of intensity of care is not necessarily associated with greater quality of care or improved outcomes, which is where this framework comes into play. Created this conceptual model that organizes rehab interventions under the broad constructs of type, place, and timing. This allows for a framework of a way to classify and understand the complexity of rehab services that are given to patients. And referring to this diagram, this framework helps to study the degree of which rehab service variability is associated with outcome differences among clinically similar groups of patients. Overall, outcomes are expected to vary according to the type of rehabilitation received, the place where it occurs, and the timing of rehab as well. Overall, this framework encourages for a paradigm shift away from visualizing single episodes of rehab towards visualizing a whole continuum of care instead. So just to go into some of the terminology, type approximates what's done to the patient, whether they're getting a specialized inpatient rehab versus consultative rehabilitation. In specialized rehab, the patients are under the care of physiatry, and the focus is on functional recovery. In contrast, consultative rehab occurs when the PM&R professional sees the patient in the acute hospital services, where they are not seen daily, and but rather are assessed based on their need and staff availability. The next term is place, and this basically reflects the setting where rehab services are rendered to the patients. It can be inpatient, outpatient, long-term care, or home. And finally, timing within rehab can be differentiated between early pattern of rehab and late pattern. In the early pattern, patients receive immediate postoperative inpatient rehab directly after the amputation. And then the late pattern is defined by the patients having a separate hospitalization for rehabilitation, and in between acute care and rehab, they've had an experience outside in terms of being home or at a skilled nursing facility. So the next section, I'll examine some of the outcome studies within this TPT framework. So in this first study, Dillingham et al. Provides insights into the relationships between post-acute rehab setting and 12-month outcomes among elderly patients status post lower extremity amputation. The differences in outcomes were determined by analyzing 2,468 persons in the 5% random Medicare sample in 1996 and 97. The setting of concern were inpatient rehab, skilled nursing facility, and home. Outcome measures included 1-year survival, medical stability, re-amputations, and prosthetic device acquisition. The results showed that overall amputees that were discharged to inpatient rehab had significantly better outcomes than patients who were discharged to skilled nursing facility, even after controlling for amputation level comorbidities and other confounders. Looking at inpatient rehab versus SNF and home, these people were experienced significantly higher survival rate. They had less amputations, were more likely to be prescribed a prosthetic limb, and had reduced admissions due to other issues besides amputations. With regards to inpatient versus SNF, patients who received inpatient rehab had superior outcomes in 3 of the 5 outcomes that were measured. This included survival probability, prosthesis acquisition, as well as number of subsequent acute care hospitalizations. So this information lends support to the notion that intense therapy services and continued medical care provided through an acute inpatient rehab facility can be beneficial for rehabilitation of amputees and facilitate greater medical stability. This next study, Steinemann et al., performed an observational study among 9 administrative databases from the VA. The researchers focused on the timing of rehabilitation, specifically on the effects of early rehabilitation. In this particular study, early rehab had a broad definition, including both consultative rehab services as well as specialized inpatient rehab. Outcome measures included 1-year cumulative survival, home discharge, and prosthetic procurement within a year. There were 2 cohorts studied. One group had no evidence of rehab, while the second group had evidence of acute post-operative inpatient rehab. Of note, let's see this, but nearly 3/4 of amputees received inpatient rehab of some sort, whether it was consultative or a specialized unit. The key findings were that compared to those who did not receive inpatient rehabilitation, those who participated in inpatient rehab were 1.5 times more likely to survive and 2.58 times more likely to be discharged home. This next study, Carucci et al., focused on the type of rehabilitation rendered to the amputees. The outcomes were compared between patients receiving specialized inpatient rehab versus consultative rehabilitation. And outcomes measured here were 1-year survival, home discharge from the hospital, prescription of prosthetic limb within a year, and improvements of physical functioning at rehab discharge. The results from the study provide strong evidence that patients receiving specialized inpatient rehabilitation were more likely to be discharged home, received prosthetic limb, and had improved physical functioning as measured by the motor FIM score. It was also noted that the patients in specialized rehab did have higher 1-year survival, but there was it was not statistically significant compared to those who received consultative care. This next study looked at the outcomes within both type and timing constructs of the TPT framework. Within the type, they assessed the ADL and mobility outcomes in veterans within the setting of specialized rehab versus consultative rehab. And further differentiation was made in regards to timing, whether these patients received early or late rehabilitation pattern. And they hypothesized that with specialized rehab, these patients would have greater gains in physical functioning by discharge, and that early compared to late rehab would achieve greater motor FIM gains. And just looking at the distribution of rehab patterns in this study, of the 1,502 cases in the analysis, 79.1% of patients received consultative services, 20.9% received specialized rehabilitation unit care, and 89.1% of patients received early pattern of care compared to late. So just looking at the results here, with regards to the type of rehabilitation, after adjusting for clinical differences and facilities where the patients received their surgical amputation, the type of rehab was seen to be a strong predictor of patients' motor FIM gains. Patients who received specialized rehab compared to consultative were expected to have an average of 8 points greater motor FIM gain scores. Next, looking at timing of rehab, it appeared that the benefit of early rehabilitation compared to late disappeared after adjusting for illness and burden and initial severity of the disability. Any apparent benefit of early rehab was more related to differences in severity of patient condition at presentation than the effects of the rehabilitation timing itself. So the study suggests that the timing in this case should be more driven by the patient's clinical readiness for services and ongoing needs rather than the expectation of greater outcomes. This next study looked at the mobility outcomes among 199 patients at VA medical centers, comparing those receiving inpatient rehab versus never receiving rehabilitation. The outcome was measured of mobility success based on the place of rehab. In this case, mobility success was defined as when the level of mobility at 12 months was the same or greater than the premorbid mobility level. They used the locomotor capability index 5, and mobility success was also studied in context of patients' social support and presence of depression. So they found that patients who were ever treated at an inpatient rehab facility were 17% more likely to achieve mobility success than not. Having greater social support was also related to increased likelihood of achieving success, and depression was associated with 23% less likelihood to achieve mobility success. Further, these patients attending a inpatient rehab facility had significantly greater therapy visits as well. Next, Steinemann et al. Looked at the survival implications of patients achieving different grades of physical independence after a lower extremity amputation. The main outcome measure here was the cumulative 6-month survival after rehabilitation discharge. Up until the time of this study, although functional disability was strongly predictive of reduced survival in individuals with varying diagnosis in rehabilitation, the association between the degree of functional recovery achieved by rehab discharge and longevity of amputations was largely unknown. So the implication of this study provided a shift in thinking about the survival outcomes. As you can see in Model 1, that there was in this particular model, there was a direct effect of patients' demographics and clinical characteristics on their survival. So the shift in thinking goes to Model 2 here, where by evaluating the function achieved by rehab discharge, these demographics and clinical features of patients have a more indirect impact on mortality risk by its main effect on functional achievement. This graph here depicts the survival rates over time amongst different FIM grades. At grade 1, which is total assistance, the 6-month survival rate was 73.5%, and that's the lower line that you see here. However, they found that even with just a small improvement from grade 1 to grade 2, going from total assistance to max assist, in the most severely impaired amputees resulted in better 6-month survival. And in fact, this resulted in the largest incremental improvement in prognosis of survival, increasing from 73.5% here to 91.1%. All right, so in the next section, we'll look into some further studies learning about patients' factors and determinants associated with specific rehab environments. And just to recap, in the first study that I presented, Dillingham et al. Had previously looked into the patterns of rehab discharges from 1987 to 1997. Among the dysvascular amputees that were studied, 40% went home without any home care, 37% went to SNF, 9% went to home with home care, and only 10% went to inpatient rehab facility. So the question is, was this based on sound health care? And having an understanding of the prognostic factors can help us as healthcare providers, as well as payers, to understand the location of rehab that would be most optimal for these patients. So while this particular study that I'm going to talk about doesn't look at specifically a patient clinical factor, Bates et al. Looked into the effect of simply having an on-site inpatient rehab facility on rehab disposition. 3 treatment groups were studied. They'd include no evidence of rehab assessments while hospitalized, rehab through consultation level services only, and patients with evidence of inpatient rehab admission after surgery. And the results of this study showed that there were no differences in consultative rates, whether or not an inpatient rehab was present on site. However, veterans with surgical amputations at facilities with on-site inpatient rehabs tend to be, or were 4 times more likely to be admitted to higher intensity specialized rehabilitation. There was evidence of, this was evident after controlling for patient and clinical differences. It was also noted that these patients had longer length of stay at the medical centers that had inpatient rehab, and this indicated that despite similarities between the groups, there may be increased severity in disease in patients after severity of disease in patients at VA medical centers with on-site rehab. Implications of this study show that the availability of post-acute care services is, or can be, a powerful predictor of post-acute care use as opposed to clinical characteristics. And also the structural differences in service availability among clinically similar populations may cause for access disparities to specialized rehab among amputees within the VA setting. This next study looked into mortality risk factors. Mortality rates at 30 days after amputation can range between 6.3 to 42.3%. And in this study, Bates et al. Assessed the mortality of patients in 3 time periods. Those 3 time periods are in hospital at 3 months and 1 year post-operative. The results here showed that inpatient hospital mortality was mortality and the likelihood of mortality in all 3 time periods was strongly associated with systemic sepsis in the perioperative period. Other factors contributing to mortality include CHF, renal failure, liver disease, and increased age. In regards to amputation types, it was also found that there was a 13-fold increased risk of hospital mortality among patients with hip disarticulation compared to transfemoral transtibial amputations, and that mortality was also increased for transfemoral amputations compared to transtibial amputations. And interestingly, in-hospital rates of mortality was lower among patients who had diabetes. So these high mortality rates attest to the frailty of post-amputation veteran population. As a result, with the determination for rehabilitation disposition, there needs to be a more careful medical oversight in the weeks and months following amputation in order to help these patients achieve their highest functioning level. This next study looked into clinical characteristics of veterans admitted to after lower extremity amputation between 2002 and 2004. The main outcome being whether they were admitted to inpatient rehab or remained on consultative rehab services. The results showed that 606 patients were admitted to inpatient rehab and 2,300 patients received consultative rehab services only. Looking at patient factors associated with inpatient rehab admission, they tended to be younger. They were more likely to be living at home before a surgical hospitalization, more likely to have unilateral transtibial amputation. These patients were also hospitalized longer from admission to their surgical dates. They waited longer to have their first rehab assessment after surgery. They had higher inpatient motor and cognitive FIM scores. And also there was a regional difference as well, that surgeries that were conducted in south-central parts of the country, and also patients who were managed at hospitals with bed size between 127 to 362 beds were more associated with inpatient rehab admission. In contrast, patients who received consultative-only rehab tended to have systemic sepsis, COPD, CHF, paralysis, and renal failure. And in terms of regional differences, patients tended to be treated or managed at southeast regions of the country. The patients in the study were found to be selected for rehabilitation level based on their level of medical complexity, as we just saw. And the decision for admission may be motivated, in this case, by medical stability and the low risk for unplanned transfer from the unit due to these medical complications. Next, Dillingham et al. Further differentiated the factors determining discharge to various locations after amputation. We looked at patients who were discharged home versus SNF. Patients who went to SNF tended to be older, had presence of diabetes, had perioperative complications. They also had amputation either the transtibial or transfemoral levels. Patients who were discharged home tended to be married, had higher levels of pre-amputation mental and cognitive functioning. And then looking at inpatient rehab facility discharge compared to SNF, patients who were discharged to SNF had previous evidence of nursing home living arrangement, and patients going to inpatient rehab tend to be younger in age, were employed, have accessible home environment, higher preoperative mental functioning, and unilateral transtibial amputation. Interestingly, these patients also, the ones who had Medicaid insurance were more likely to go to inpatient rehab compared to their counterparts who had private insurance. The reasons were not clear, but may be related to the policy of public insurers to allow inpatient rehab without as much case management oversight. In contrast, private insurers frequently review patients' evaluations and potential for rehabilitation, and then either approve or deny coverage for rehab admission. Such administrative hurdles are postulated to may have influenced the likelihood of inpatient rehab usage. And it's just a chart showing that information I mentioned. Next, we'll discuss some of the current policies and challenges within this population. Overall, there's no standardized protocol for decision-making for rehab disposition. In 2007, the Department of Veteran Affairs and Department of Defense created this guideline in which the decision-making process should be made on a consideration of medical status, patient's current and medical and anticipated function, the ability to participate in rehab intervention, patient's social support system, and community resources. And overall, the guideline that they gave us in 2007 were pretty generalized. Among the rehab levels, patients should be medically stable. In a situation of home discharge, patients should also have the ability to transfer with assistive device, perform ADLs, and have accessible home environments. In regards to the other 3 levels of discharges shown here, it basically boils down to the patient's ability to follow commands and tolerance to varying levels of therapy intensity. Now, in regards to challenges with rehab disposition, I previously mentioned the issue of private insurance administrative hurdles. In 2001 and 2004, the Centers for Medicare and Medicaid Service published final rules implementing a new prospective payment system and policy changes regarding case mix diagnostic criteria used to determine which private sector programs were eligible to receive reimbursement as an inpatient rehab facility. From 2004 and 2006, there was an estimated 19.2% decline in the overall inpatient rehab caseload and 13.5% reduction in a number of lower extremity amputations who were treated. Further, the substantial reductions in median length of stay for the general population in inpatient rehab have been shown to be associated with increased mortality at 80 and 180 days post-discharge follow-up. So the key conclusion from this information is that with ongoing reductions in rehabilitation availability, this can have tangible and detrimental effects within lower extremity amputees secondary to this vascular disease. So next, I'll talk about some recommendations based on the data presented here. Given the guideline provided by the VA and Department of Defense, how it was pretty generalized, I think there needs to be an algorithm of some sort to help clinicians make rehab disposition decisions on an evidence and systematic basis. The evidence presented in this paper or in this presentation it's clear that patient status post lower extremity amputations would benefit from inpatient rehab. However, the question does remain who exactly qualifies for this level of care. So based on the information I've gathered, I've come up with this algorithm of sorts regarding the decision-making process for this group of patients. So basically, I believe that all patients who've received new major lower extremity amputation should receive post-operative pulmonary consultation. And within this consultation, they should be risk stratified based on various factors, one being age, where we've seen in this presentation that younger patients tended to be more favorable or have more favorable outcomes with an inpatient rehab. The next factor would be socioeconomic factors. Patients with good support system, those who were married, have an accessible home environment, are more favorable for inpatient rehab disposition. The FIM score is another factor as well. Patients within the intermediate range of the FIM score would most benefit from inpatient rehab. There should also be a reasonable expectation for these patients to make gains in FIM grade as a result of their rehab course. The next thing would be medical complexity. This includes consideration of patients' comorbidities and perioperative complications. with increased number of comorbidities such as CHF, renal failure, and liver disease, and the presence of major complications such as sepsis, these patients would probably more likely benefit from consultative rehab, where the level of care is a little bit less intense, and this allows for these patients to have closer medical oversight. And finally, amputation level. As we've seen, there's clear mortality impact in patients with higher level of amputation at the transtibial level and hip disc articulation compared to transtibial amputations. Overall, not just any one of these factors would make or break a patient's decision versus disposition, but rather it should be taken overall everything in consideration, and with the goal of starting rehab therapies as soon as these patients are medically stable. So I know this might be a mouthful, but I like to call this Nguyuen's Guide to Optimal Rehabilitation, Disposition, and Lower Extremity Amputation, or the Nagorlia algorithm. So this is just reiterating the same thing there. Finally, just some conclusions. So dysvascular disease is the most common cause of lower extremity amputations. The prevalence of lower extremity amputation is expected to more than double from 2005 to 2050, prevalence estimated at 3.6 million. And this has clear impact on healthcare costs and in functioning and quality of life in these patients. What we've seen so far is that despite the positive outcomes that we see with inpatient rehab, that that discharge to these facilities overall are quite low. And by usage of inpatient rehab, this can have major effects on mortality, mobility of these patients, medical stability, and eventually discharge to home. So far, there's no consensus on standardized protocol regarding rehab disposition in this population. Future considerations should include the standardization of methods to determine the most appropriate rehabilitation discharge setting for patients undergoing amputation. The recommendations I made in this presentation are based on the studies reviewed and would provide an evidence-based approach to guide clinicians in determination of the optimal setting for rehab disposition after low extremity amputation. These are my references. I want to thank my advisor, Dr. Yu. Special thanks to Maria Lucas, physical therapist, and food from Crystal. I just wanted to show something as well. So as some of you guys know, I am interested in magic, and I just wanted to show this video. It's a magician. His name is Rene Lavande. He's one-handed. He had a traumatic amputation of his right upper extremity. He's from Argentina. He actually died last year, but he shows a pretty cool magic trick. It's called oil and water, and basic premise is in mixing different colors of card, black and red, he'll show you something that's pretty remarkable. Let me see if I can show that.
Are 6 cards. Here are 6 cards. 3 cards are black, negras, and 3 cards are red, rojas. No voy a prestidigitar. Now, I'm not going to do this quickly. Una carta negra. 1 black card. Here. Otra carta negra. Another black card. Here. Y otra another black card. Here. Roja, red, red, red. Roja, red, negra, black, roja, red, negra, roja, red, negra, black. No se puede hacer más. I can't do this any slower.
That's just a little